Okay, there we go. Thanks, Jess. So here's our agenda for today. If you have any questions during the webinar, feel free to direct message our program manager, Jessica Warner, or just ask in the group chat. And since I just started the recording, I'll just back up. We're going over arthritis today. And if you schedule an appointment during our time today, you'll receive a $15 gift card for attending your first visit. And you'll do so by texting a number that we'll post in the chat, and then we'll include in an email after. So this is perfect timing for our webinar because May is Arthritis Awareness Month, as recognized by the National Institutes of Health. As wellness specialists and PTs, it's amazing to see all the research that supports staying active as one of the best ways to manage arthritis. And just a little hint, this is a theme of our webinar, but likely not much of a surprise there. Even the CDC states that the top 3 ways to manage arthritis are to learn self-management skills, be active, and talk to your doctor. And in our case, that is your dedicated doctor of physical therapy who specializes in bones, joints, and muscles, all of which can be affected and treated in those with arthritis. And just a quick note, what does it mean to learn self-management skills? This includes strategies to increase confidence, knowledge about arthritis, psychosocial well-being, goal setting, and action planning. So we'll learn today that managing arthritis goes far beyond treating the affected joint. And it's just really great to see the big players recognizing this too. There are many types of arthritis, but the most well-known are osteoarthritis, OA, and rheumatoid arthritis, RA. Osteoarthritis is the most common form. It's most frequent in the larger weight-bearing joints like the hip and knee, and it's also seen in the hands and spine. It's generally diagnosed in those over 55 years old. Diagnosis is usually based on symptoms and imaging, but today I'll share how imaging is overused, and we can diagnose very well with clinical findings. Rheumatoid arthritis is an autoimmune disorder. It usually affects people in their 20s to 50s. Women are diagnosed 2 to 3 times as often, and we first see swelling in the small joints in the hands and feet. It's often diagnosed with clinical signs and blood work, and about 80% of people diagnosed with RA are positive for rheumatoid factor. With both, we see pain, inflammation, limited mobility, and difficulty with daily tasks. Some fast facts: you can reduce your risk of developing certain types of arthritis by limiting inflammatory or processed foods, avoiding smoking, and staying active. You can slow the progression. So even though there's no cure, you can absolutely manage symptoms, increase functional strength, and improve your quality of life.
Morning.
Lastly, and I think as people are listening, we'll just make sure to be on mute, but thank you guys. Lastly, loss of cartilage or wear and tear is not the primary cause of arthritis pain. So let's debunk wear and tear. So this very common thought that the breakdown and loss of cartilage causes joint pain. So OA is actually a mild whole body inflammatory process. Hyaline cartilage is avascular and aneural, so there's no blood supply and no nerve endings. So cartilage is not the primary pain generator. And studies trying to correlate imaging and cartilage loss to pain level showed inconsistent results. So if cartilage breakdown is not the primary pain generator, what does cause pain with OA? And I'll dive into that low-level systemic inflammation in the next slides. But also, there's been shown to be inflammation and thickening of the synovium. So the synovial membrane is a barrier that lines the inside of certain joints, and the synovium and the cartilage are both parts of the joint. The synovium produces fluid that helps protect the cartilage, and the cartilage helps cushion the surrounding bones. So by staying active, we help the joint move smoothly as it produces and moves the synovial fluid. There could also be some nervous system sensitivity, whether it's local nerves around the joint or more of a baseline hyperactivity of the nervous system. It could contribute to how we feel pain. We have some great blog posts on this, and we'll link the blog at the end. There could also be muscle weakness surrounding the joint or compensatory gait and movement patterns. There's an amazing book called Epiphany that focuses on knee OA, and it has incredible resources, and I'll reference it again here later. But here's a few old and new school thoughts surrounding OA that are mentioned in Epiphany. So the old school thinking is that OA is caused by age, injury, and overuse. And new school evidence actually shows that thoughts, sleep, stress, diet, strength, comorbidities, and social support can all contribute to OA. And I'll just read some of the new school thoughts here. So yes, surgery can be avoided. Just because you have OA does not mean you are bound to need a joint replacement. Symptoms can improve, and exercise helps at all stages. So it's never too late to get help and to start treatment. Epiphany highlights 3 critical ingredients to treating OA. Number 1 is activity. So increasing physical activity can make you stronger, more agile, improve confidence and mood, and also reduce inflammation. Number 2 is knowledge. So knowing how to reduce your body's stress response, empowering you to help yourself and others with OA, and enhance problem solving and goal setting. Number 3 is inflammation. So reducing inflammation can help you move better, think more clearly, and improve structural health. Inflammation can be local, like swelling, redness, or warmth, but not all inflammation is local. And some is good for us, but too much is not. Certain health conditions can affect inflammation, but also things like stress, anxiety, work or relationship issues can impact inflammation. But the knowledge that OA is linked to inflammation is actually good news, because this means there are many ways to change it. So through activity, positive social interaction, managing diet, de-stressing strategies, etc. And I will circle back to that in a bit. So with that, let's take a quick pause. If you have any questions, feel free to post them in the chat, or you can unmute. And for anyone who can or would like to join, I want us to stretch. You can also take this time to schedule a visit if you'd like by texting that number. And just to clarify, the appointment does not need to be today, but we want the visit to be scheduled today, and that's how you'll get the gift card when you attend. So for those seated, I'll lead us through a couple seated and then some standing stretches. It'll just take a minute or so. But when we're sitting, a nice upper back extension can feel really nice to just kind of counteract the sitting that we do. So you'll support your neck and then have that movement come from your upper back. And you can turn your video on if you'd like, or just follow along with me here. You can also do some neck rotation. So looking over your shoulder, applying a little overpressure. This is nice because it forces you to take your eyes off the screen too during the workday. If you can stand, a nice hip flexor stretch can feel nice and relieve some low back stiffness. So if you have a rolling chair, support it with your hands, but you can put one foot on that chair and just lean forward. Yeah, so I'll show you on the other leg too. So here I'm stretching the back leg and the front of the hip there. Standing up nice and tall as we do this.
Oh, yeah.
Yeah, that one feels great if you've been sitting for a bit too. As you're up here, we could try just touching your toes, nice hamstring stretch. Probably know that one. And then even some side bending through the torso can feel really nice. Just realized I'm matching my couch back here. Usually I have my dog on there, but she's kicked out for the morning. Okay, any questions before we move on? Alrighty. So now we'll review imaging and then treatment options for arthritis. And then once we get to the physical therapy piece, you'll know we're close to the end because, of course, we saved the best for last. So earlier I mentioned how imaging is overutilized for musculoskeletal conditions, and this definitely applies to the arthritis population. Despite guidelines recommending against imaging, for example, the rate of lumbar spine MRIs in the US is growing at a 300% rate. And it's been suggested that up to 2/3 of those images may be inappropriate. On top of that, in the cost, the evidence is not showing improved patient outcomes. What it does show is a 2 to 3-fold increase in surgical rates. And just a fun fact, surgery rates are highest where imaging rates are highest, and surgery rates are also highest in areas where there are the most surgeons. So just thinking, why is it harmful to order imaging just in case? Aside from radiation exposure with CT scans and radiographs, image findings often don't guide treatment, but can look or feel really scary. For example, a study among asymptomatic people 60 years and older showed that over 90% had a degenerated or bulging disc. So over 90% had imaging findings without any low back pain. Heidi calls these kisses of time, and these often don't equate to pain level. Also, if any of those asymptomatic subjects developed back pain, they actually did a repeat MRI 5 years later, and 84% had unchanged or improved lumbar imaging findings, even after symptoms developed. So, explaining that, herniated or bulging discs can resolve, and disc degeneration, again, is usually not the reason for arthritis-related pain. But a patient's knowledge of imaging abnormalities can actually decrease self-perception of health and may lead to fear avoidance and catastrophizing behaviors. It may actually predispose people to chronic pain. So we're here to try and avoid that altogether. There's a place for imaging, and physical therapists screen for flags that would indicate that need, such as neurological symptoms like progressing weakness, coordination or gait changes, also systemic symptoms like infections or cancer. But the American College of Physicians and the American Pain Society state that clinicians should not routinely obtain imaging or other diagnostic tests in patients with nonspecific low back pain. So if imaging can lead to surgery, let's talk about the issue with surgery. And in our case with arthritis, this may be a spinal fusion or a joint replacement. We also get asked about debridement and arthroscopic surgeries, so removing some cartilage, but this doesn't show much benefit either. So surgery itself does not guarantee a relief of pain because, again, it might not change or address the pain generator. Unnecessary surgeries can actually be associated with worse outcomes. There's also always the risk of complications with surgery. You may even need a revision surgery. So knee replacements, for example, are becoming more advanced, but they still often last about 15 years. And with spinal fusions, there's the risk of needing surgery above or below that joint. And just thinking of the rehab process afterwards, it's a lot. Again, there is a place for surgery as well. For example, if you have a fracture from a trauma or worsening neurological symptoms, though these are rare in the arthritis population. Then also if you're not responding to conservative treatment. But as I was researching, even the arthritis.org page states that the bottom line is to try everything else first, understand that surgery isn't a cure, and they even also state that a second or revision surgery is possible. And I'll wrap up by saying it's important to look at the full picture. So we've had patients that ended up undergoing a joint replacement, like a hip or a knee, and who have done really well. And we've worked with them pre and post-op, and it's great to see their progress, but it's definitely a case-by-case basis, and it's important to seek non-invasive measures first. I know that's a lot of info, so feel free to do some of those stretches again, move, take a deep breath. Okay, so let's talk non-surgical treatment options. So with injections, there's a similar theme here. There's a place for injections, and that's primarily for short-term pain relief. Corticosteroid injections can improve pain and function for a few weeks to 3 months. Those are most commonly done in the hip, knee, or shoulder. I think we have someone who is not on mute. I'm sorry. But those corticosteroid injections are most commonly, done in the hip, knee, or shoulder. The efficacy of spinal injections is limited. Studies have shown that it may offer temporary relief of sciatica, but for back pain without sciatica, there's not much evidence of benefit. And it still doesn't really reduce the rate of surgery because the pain can return. But if an injection may help you move more and follow a structured PT program with less pain, we're open to talking about it, again, on a case-by-case basis. But there can be long-term harm due to cartilage damage, so we'll go through all that during our visits. This last piece is a chunk from our previous webinar where we referenced a study that showed that patients with OA who received PT had better outcomes at 1 year compared to those who received an injection. Some medications for OA, there is evidence for topical NSAIDs like diclofenac or Voltaren. Those go on the skin and can often be purchased over the counter. Also evidence for oral NSAIDs like ibuprofen or Advil. But over time, this can cause increased risk of cardiovascular and GI issues. As a whole, the evidence is against opioids. And I will say, I've noticed in general, we're becoming a lot more educated about the danger of opioids. And I rarely have patients asking about or seeking them, which is great. Most of the time, my patients are wanting to avoid those, and we're figuring out every way to do so. So it's been great to see that. Quick note, this will look a little bit different for RA. DMARDs are a common medication, and then NSAIDs for short-term relief. So on to PT, our favorite part, and the benefits of PT and exercise. So there isn't a cure for arthritis yet, but it can be managed. We can slow the progression, and we can keep doing what we love. And the best part is it does not need to be complicated. So at Aware, we review strategies to control pain, improve or maintain physical function and quality of life, with a focus on mobility, strength, assistive devices when needed, even techniques for stairs, sleep positions, controlling inflammation, and just overall staying active and finding a routine that works for you. So will exercise damage your joints? The short answer is no. And it's really hard to understand when we always hear wear and tear. So why would we work out a joint that's already worn down? But it's actually quite the opposite. So exercise does not have a negative effect on structural longevity and does not increase inflammatory markers. Some benefits of exercise: improve strength, so muscles get bigger when loaded. Bones get tougher when under pressure. Exercise increases tendon thickness. Exercise can relieve arthritis pain and stiffness, boost energy, and create this positive feedback loop with improving diet, hydration, and sleep. So really taking a whole body approach. And just remembering those three critical ingredients: activity, knowledge, and inflammation. So some tips for managing pain during and after exercise. Firstly, any form of exercise can be beneficial, but it's important to work with a professional to find the right balance and style for you. You can modify, just don't stop. So for example, take a 1-minute stretch break for every 1 mile you walk or run versus just stopping walking altogether or running. Have a proper warm-up and cool down routine. You may even find yourself enjoying a morning mobility routine. Morning stiffness can be pretty common with osteoarthritis. So just having, a couple movements that you can do before you get out of bed or, right after you walk around a little bit would be great. And then trying different types of exercise, for example, yoga, Pilates, or water aerobics. And you can definitely keep doing some high intensity, but these are just other options. And this really could be the silver lining to picking up a new hobby and even socializing while you work out. So some key takeaways: OA requires a whole body approach. It goes far beyond the affected joint or joints. Imaging is often not necessary for arthritis. We can diagnose and start treatment if you have pain and or suspect you have arthritis, and we may not ever need imaging. So it is really crucial to start with non-invasive options like PT before jumping to injections or surgery. And we'll work with you to find the right exercise program, identify any barriers, set goals, and support you along the way. So if you're new to Aware or you didn't catch it at the beginning, don't forget to schedule if you have any muscle, joint, nerve, or bone pain. We also treat pelvic floor weakness, or if you think you have arthritis or have been diagnosed with arthritis, or just if you want to get started with a general health and wellness program, we are here to help. All righty, we're at the end. So any questions? Again, feel free to unmute if you'd like, or ask in the chat. I haven't been able to see the chat, but I'll stop sharing here and catch up. But before I do that, any questions? I'll stop sharing.
Siobhan, there are a few in the chat.
All righty.
Can my Aware Health PT help me create a plan for activity and inflammation?
Yes, we definitely can. So inflammation again might look a little bit different for everyone. It could be local, could be a little bit more systemic. And there are definitely ways to combat those in both senses. So yes, it's not like a one size fits all, but that's why we work with everyone, yeah, and find a personalized treatment plan.
Okay. And then second question, I have an image that shows I have OA. Can I reverse it?
So we don't necessarily think of it as reversing it. But again, we can slow the progression. And a lot of the times OA even gets used, and Heidi and Caitlin, you guys can jump into, but kind of gets used as an umbrella term. We all have a little bit of degeneration or OA, like that even starts in our 20s and 30s. But again, some people are completely asymptomatic and would show those. And then some people who are in a lot of pain might show very mild OA on an image. So it just doesn't correlate all that well. But to answer your question, it's not necessarily about reversing it, but we can slow that progression and have it so that your symptoms don't correlate with what, may be showing on that X-ray.
Okay. And then also another question is, it is free for me and my dependents.
Jess, you want to take that one?
Yeah, it's free. Yeah, so Aware is free for everyone here. Your employer covers this fully 100%. You can use Aware for any muscle, nerve, or joint point pain, not just anything related to arthritis. That's just our topic for this quarterly webinar. But it's always free. Depending on your company, it's your company name, .awarehealth.io, and that's how you make an appointment. You can always reach out to us as well to get the appointment link. And your dependents are covered as long as they're 12 years and older.
Great question. And thanks, Jess.
Mm-hmm.
Perfect. Like I said, if any other clinicians want to hop in, but I think, yeah, I think we covered it. Any other questions in the chat? We have a minute or two left. All righty.
I have a question, Dr. McDonald. How can telehealth help if I'm bone on bone on my knee?
Oh, telehealth can definitely help. Dr. Oja, thanks for asking. So it is very, very beneficial to be on telehealth also, because you can do appointments directly from your work or home. We could go on a walk together. But we have different video tracks that link to strengthening different parts of the body. We write down your treatment plan so you can access that at any time. Oh, someone just popped in. I'll let them in. And just being on telehealth, we can definitely still assess, like I said, your mobility, your strength, find the points that we need to work on, and just find a program that fits into your schedule. And we get to learn about what that looks like. And then we also have some flexibility to, just kind of have more of an open chat with it being one-on-one, about any other factors that are going on. Like I mentioned, that may be contributing to your OA. So like stressors in your life, sleep, habits, hydration, diet. We have a bit more flexibility even than in a traditional clinic to address all of those. Ooh, good question. Does surgery increase the risk of OA? I don't know if I have a good answer for that, but for example, with having a spinal fusion at one level or even at a couple levels, your movement has to come from somewhere. So it's going to come from the area above and below. So again, you might be at risk of needing another surgery, but I'm not entirely sure if it increases the risk of OA. That's a very good question.
Just to chime in here, this is Heidi. I'm the founder of the company. And I know that especially with meniscectomies or meniscal repairs, there's a higher risk of developing arthritis afterward. Basically, anytime you go into a joint, like the knee joint surgically, it does increase the risk of developing arthritis afterward. So just something to keep in mind. But as we said, the wear and tear that happens because of that, though, isn't necessarily correlated with pain, like Dr. McDonald's saying. So it's just kind of something that happens at an accelerated rate after, going into the joint surgically, but that doesn't always, it's not always associated with having pain.
Thank you. Yep. Great answer. And yeah, those are major surgeries. I think they've become a little bit normalized. Like, oh, just go in. They're almost like outpatient procedures now, if this is how people think of them. But it is a lot on that joint. When I was in PT school, I sat in on a day of surgeries in the OR, and like those hit, and they were mostly ortho surgeries, like knee replacements and hip replacements, and not to cause a scare or fear, but it's it is a major surgery, so it's I could totally see how that would affect the joint. I have another question. Just can you please talk about more about steroid shots and how that can help? So corticosteroid injections are basically a powerful anti-inflammatory. So linking back to inflammation, that's why they can provide short-term relief. And again, Dr. Oja or Dr. Hall, feel free to jump in, but that is kind of where we see the relief, is if you're helping to decrease inflammation, but there are other ways to do that as well, aside from an injection. But that's what a steroid shot is. It's basically just an anti-inflammatory. Yeah, these are all really good questions because we hear so much about it, but it's hard to know what next steps are for you. But again, just trying something non-invasive, something that can work in your schedule and not cause, harm or side effects, is always a great place to start. And Jess, okay, perfect. Of course. All righty. Well, we're right at 8:30. So thank you all for joining. I know it's early for some of you. So I really appreciate it, and have a great rest of your day.
Dr. McDonald, I just
Yes.
wanted to put in one more plug as the
Yes.
founder that if all of you who joined today can just give us feedback on the platform by hopping on, you get a gift card as a side benefit, but just give it one visit. You only need to do one visit if that's all you want to do, just to get advice, and doesn't commit you to anything long term. If you do see the opportunity and want to work on things together, we're happy to see you for unlimited visits without a cap. But I'm being the founder, really curious on what your experiences are with the platform. So if you can use it and share that with us, and give us critical feedback, like this really worked for me, or I didn't like this part, and we're in the stages of building our platform, and all of that input can really help us. So if you wouldn't mind booking an appointment just to give us that feedback, that would be really appreciated from me to you.
Absolutely. And our appointments are about 25 minutes long, so they're quick, but we do get a lot done. We're pretty efficient. We've learned how to use that time well. Thank you all.
Thank you.
Thanks, Nadia.
Welcome.
Thanks for joining.
Yes. Thank you for your time. Take care.
Okay, thanks, you too. Oh, I see golden.
Thank
I
you.
look just like it. Thank you.
Thank you so much for this. It's nice seeing you.
Oh, good to see
You
you.
look so pretty, Dr. Siobhan.
Oh, thank you. You're so sweet. Oh, I will see you soon, right?
Yeah, I will.
Okay, great.
Have a good one,
Thanks
okay?
for joining. Have a good day.
Thank you for giving this presentation, okay? Have a good one.
Oh, thanks, Mona.
Bye.
Bye.